Hello and good morning, mummies, and good morning, Annabelle, who we've got on the call this morning. I'll start with a little introduction of why we actually came up with the topic for this coffee morning. I think a lot of our mummies, more and more of our mummies, and I think Annabelle will shed some light on that as well, are diagnosed with gestational diabetes. The reasons for it are multifaceted, and I think that's what we're going to learn about today. But I was just saying to Annabelle, actually, learning about how to manage your blood sugar is so relevant not only to gestational diabetes, it is so relevant for all of us who are heading into perimenopause in the older years and so on and so on. It is just, and even actually for our kids and giving them a good start and learning to be conscious about what they eat and have a balanced meat as well so that their blood sugars are in a good place. Okay. Annabelle, I'd like you to start sharing your presentation. You've prepared a lot of content for us, but we still have questions. Sorry, we still have space for all of your questions. So please, mummies, daddies on the call, write it in the chat, and there might even be an opportunity at the end for you to speak directly to Annabelle as well. Okay?
Thank
Take
you
it
so
away.
much.
I'm so excited to have you.
Thank you so much for having me. I'm really excited to be talking about this. This is a big area of interest, and you'll see why in a couple of slides. But let's jump straight into it. My name's Annabelle. I'm a dietitian. I'll cover a little bit about myself because I think I'm new to this wonderful community that you've built here, but it sounds like it's a great community. We'll talk about gestational diabetes, what diagnosis looks like, because it can be confusing for a lot of people, how we manage blood sugars, how we look at diet, and what postpartum can look like as well, because that's also really, really important. So a little bit about me, I'm a dietitian. That means that we have to complete, quite a few years at university to get trained. I say this because the nutrition space is a really confusing one. There are lots of Instagram nutrition experts, but it doesn't mean that everyone's got the qualifications. And people get so stressed over the advice they see online. So my approach is try to reduce the stress because I don't think stress is healthy anyway. So if you are getting nutrition advice online, my advice is to always just look at the credentials behind someone and make sure they're registered or trained. And if it's really scary information, like they're telling you that this is going to be toxic and kill you really quickly, then it's probably not the best advice because nutrition doesn't have to be super stressful. I'm a mom to two cats. In the picture below, that's my cat and my dog. But I also have a baby girl that was born Christmas Day last year.
Very nice. I really think you're so right. It's a jungle out there. And I find also with introduction of solids, which is relevant for lots of our moms as well, lots of unsolicited, unfounded advice, not evidence-based and so on. So yeah, good to hire an expert.
And the reason why I'm so passionate about gestational diabetes is because I had gestational diabetes too. And despite being a dietitian and knowing everything I know, I've worked in diabetes for years before I got diagnosed. It still was trial and error for me. It was still emotionally a very involved journey. It was difficult. And I thought to myself, my goodness, even with all my knowledge, this has been such a ride. I can't imagine what it's like going in without any knowledge at all. And also a lot of the information out there isn't really up to date. A lot of it's based on guidelines that are pretty old. So I really wanted to work in this space to change it, especially knowing that our rates in Singapore are so high. And honestly, working in this area, I think having gestational diabetes myself, although I wouldn't wish it on anyone, was a big blessing because when I talk to moms, I completely understand what it's like. And we all know that pregnancy is intense. Like the things that you say or do in your last couple of weeks, you're like, on hindsight, that seemed a little bit wacky. But then and there's so much going on that it's just overwhelming, much less with this massive diagnosis and this massive responsibility you feel over your health and your baby's health as well. So, I'm not glad that I had gestational diabetes, but it really has made me a better dietitian to work in this area. And my husband, bless him, always reminds me that, it just helps me so much professionally as well, which I'm grateful for. So just covering a little bit more about gestational diabetes, essentially it's high blood sugar anytime that you're pregnant. So as long as you're pregnant, if you've got high blood sugar, that will be categorized as gestational diabetes. It's quite different from traditional diabetes or type 2 diabetes that we're more usually talking about. Essentially, there are a few reasons why this can happen. During pregnancy, a lot happens hormonally, we know. but your placenta makes hormones that can also stop your body from using insulin as it should. And this is a normal part of pregnancy. Ideally, your body can keep up with this and will make more insulin as pregnancy goes on. But not everyone's able to do that. And if you can't do that, sugar builds up in your blood instead of being absorbed. And this buildup is called hyperglycemia. Hyper means high, glycemia is blood sugar, so it means high blood sugar. So that's in a nutshell why gestational diabetes happens. In Singapore, it occurs in 1 in every 4 to 5 pregnant women. That's about 20 to 25%, which is incredibly high, looking at the global rate of about 7%. So we have really, really high rates in Singapore, but we also know that in Singapore, we've got one of the highest rates of diabetes in the world, type 2 diabetes, that is. And we know that this is association there. Personally, my risk factor was that I've got lots of immediate family members. So my father has diabetes. All my grandparents have diabetes. So genetically, there is very strong predisposition. There are other factors like being Asian, being South Asian, and I meet all those as well. So we know that there's a very strong genetic component to gestational diabetes, but the rates are going up for sure.
And I think there's also in Singapore, I think a little bit, there's not as much awareness, I think, on healthy eating and so on. In a country where for the longest time Milo was touted to be a health drink, when it has more sugar than Coke, and that is very recent actually, and still allowed in Malaysia. So I think the awareness is increasing for sure, but I think a lot of Singaporeans have been dealt a bad card by their mothers not managing their blood sugars because there was not that awareness yet, or that testing didn't exist. So it's definitely tough. And diabetes is the #1 health crisis here. So it's important to shed a light on it.
And Singapore is an interesting country where if you compare us to a lot of Southeast Asian countries, our diet is a lot more westernized as well, which could be part of the reason as to why, if you look at our colorectal cancer stats, we sort of sit right in the middle between Asian countries and Western countries. So I do think diet definitely plays a big role in it, and education is a big part of it as well. But we do know, I guess, that's the illness has exceeded us, and we really have to catch up now in bridging this gap of education and hopefully getting on top of it. Because like with all things, diabetes is really an illness where you can have it and manage it well, and you'll be completely okay, which we'll talk about in the sense of pregnancy. But even, with regular type 2 diabetes, people who have it and control it well don't end up with all the end stage complications. But if you don't manage it, you end up with, loss of limb, kidney failure, and things like that. So diabetes is really one where the management is key.
Yeah, absolutely.
So upon diagnosis, the first reaction a lot of people have is shock and maybe denial, which is completely normal, because who wants to get bad news when you're pregnant? I feel like every single ultrasound appointment, it's already like holding your breath when they're scanning to make sure that like, okay, is everything fine? Are all the organs fine? And getting a negative diagnosis is a shock to so many moms. So your first reaction is like a little bit of shock, a little bit of denial, which I understand. And then I also hear a lot of like, oh no, don't take it seriously because the rates have gone up. Basically, now everyone has gestational diabetes. I know someone who had gestational diabetes and they didn't do anything and they were fine. But I just want to cover a little bit more as to the research behind why the rates have gone up and why the criteria has changed, because I do think that this knowledge can be really empowering for you to understand why this is, but it can also change the perspective if you've had a recent diagnosis as well as to how you see your diagnosis, I guess. So firstly, the diagnostic criteria was changed quite recently. So it's formally changed in 2013, so about 10 years ago. And the main thing that we saw was that fasting cutoff was brought a lot lower. So it used to be the same as how we diagnose type 2 diabetes, which was problematic because inherently we do know that most people have lower blood sugar in pregnancy. Just because your blood is more diluted, you have a lot more blood volume in pregnancy. So we do expect that blood sugar levels to go down. So it was never a lot of research behind that first number, that 999, like fasting number. There was not a lot of research behind that. There is research behind the 2013 number, which we'll jump in the next few slides, but that number was brought down significantly. So yes, there was a change in criteria. And yes, applying the new criteria meant that diagnosis would have gone up about 45%, which is really significant. But I guess we'll see why that's important in the following slides. So all that was based off this really big study. And this is sort of the main study that supports gestational diabetes diagnosis at the moment. It's called the HAPO study. HAPO stands for hyperglycemia and adverse pregnancy outcomes. It was a really big study. It had 25,000 pregnant women, and it started with more. This was the final inclusion number. So it started off with way, way, way more. Now, I think it was close to 50,000, but just based on people dropping out and not following through or not meeting criteria, 25,000, 15 centers across 9 countries. The other thing we ask ourselves as health professionals as well is how applicable this population is to our population. And you'd be glad to know that in these 9 countries, countries like the UK and the US were in there as well, but also countries like Hong Kong and Bangkok. So population-wise, quite diverse, and it did include Asian populations as well. So what they did was they did the 75 gram tolerance test, which is what we do in Singapore, and they looked at outcomes like birth weight above the 90th percentile, cesarean delivery, hypoglycemia with a newborn, cord blood serum C-peptide, which is a marker for metabolic health. And they also looked at secondary outcomes, so preterm labor, shoulder dystocia, birth injury, need for NICU, as well as preeclampsia and things like that. So essentially, they took a whole bunch of women from different countries, very diverse, and they looked at a whole range of negative outcomes. So what they found was that there was significant associations with higher blood sugars and both the primary and secondary outcomes. So essentially, the higher the blood sugar, the higher the risk. There was no obvious threshold, so there wasn't like a clear number where we know the risk was higher. So it's very hard to say that, like at 7, the risk increased. What they did see is that there was a continuous relationship, which meant that the higher the blood sugar, the higher the risk. And the more time spent in that higher blood sugar range, if you think about percentage of your 24-hour day, the more time you spend in that really high blood sugar range, the higher the risk as well. So because of this, they decided to bring that criteria down for pregnancy to diagnose gestational diabetes. And the one thing I always tell parents or moms who are newly diagnosed here is, yes, we know that you've just got diagnosed. That's not ideal, but let's monitor your blood sugars. If your diabetes is such that you don't really have to change much and your sugar is actually all well within range, then at least we know that we've checked and your sugar is good and we're all good. But if you've been diagnosed and we're checking your blood sugars and we see that your blood sugars are high, then at least we've got something to work on to bring them down. The other side as well is that we know insulin resistance goes up in pregnancy. So although, at the point of testing, let's say you're like 30 weeks, your blood sugars seem okay, there is a chance that at 35 or 36 weeks on the same diet, your sugars could be higher. And ideally, we don't want those sugars to be high. So looking at all these together, essentially monitoring your blood sugars is a good idea, especially if you failed sort of this, I sort of call it like a stress test. Like nobody really drinks 75 grams of pure sugar at one go, but it is a stress test. So it is a useful one.
So Annabelle, I have a question here, and that is, I've seen a lot of moms who, obviously diabetes is not visible from the outside, nor is the risk, but I have seen a lot of moms who have a very, very clean diet.
Yeah.
They are, really watching it. They're super aware. They exercise a lot, all of that. So you would think they are definitely not in that category that will develop GD, and yet they got a diagnosis of GD. And then I hear, well, their body is not used to all that sugar, and of course the body is going to go into a tailspin. What is your take on that?
I feel like there could be some truth behind that. And I think that's the power of, yes, we diagnose you today, but then we don't go on and like start insulin and do all these things first. Generally, there's a time where we're monitoring you. So let's say you generally eat a really good diet. We diagnosed you with that 75 gram like drink today, but then we monitor your diet over the rest of the week your blood sugars over the next week, and you're eating a usual diet, you're exercising, and your blood sugars are completely fine. We realistically don't have to change anything. We just have to sort of monitor throughout pregnancy, and nothing really has to change. So I guess that's the beauty. And to be honest, I feel like I fit into that category where I ate fairly well. And when I was diagnosed, I felt really cheated. Like I exercised, I ate well, I'm a dietitian. Why me? But true enough, I monitored my blood sugar and it was high. So as much as I wanted to deny it, like it was high, even on a fairly balanced diet, I had to really cut my carbs back lower than anything I've done before. I had a really strict carbohydrate threshold. So it really depends on the individual. But again, I tell people, if we don't have to change anything, then we don't have to. Your sugars are fine. But the goal really is, lower sugar levels or sugar levels within range, I guess.
Yeah, and I think it's so reassuring for moms to know that even people like you who are so aware, they can still have that risk of diabetes as well. So
Yeah.
it's not, yeah, what you eat.
Your hormones do really weird things in pregnancy.
Not just in pregnancy. Yeah.
So yeah, at that point, there was another big study called the Australian Carbohydrate Intolerance Study as well. And that also showed that there was reduced, perinatal morbidity and mortality when we did treat gestational diabetes as opposed to no intervention at all. So I guess this study also says that even if there's a suspicion of like slightly impaired glucose tolerance, it's a good idea to sort of treat it first. And then we can, we don't want any adverse outcomes. The worst case, we just were like a little bit too, proactive and your sugars look fine. And then we can be a bit more hands-off, I guess.
Mm-hmm.
So some risk factors, and again, not everyone will have all these risk factors. I dare say, from personal experience that a lot of it's also genetic, but things like having a higher body mass, having previously had gestational diabetes is a big risk. So if you've had gestational diabetes before, then we generally test earlier, like first trimester onwards, in your subsequent pregnancies. History of PCOS, pre-diabetes, being older. And again, this age, some say 40, some guidelines say 40. Some guidelines would classify anything over like 30 as older and higher risk for GD. And we know that most people now are having kids later anyway. So and having family history of diabetes, which if you're Singaporean, you probably have.
People would have, yeah.
In Singapore, we do the OGTT 75 grams. This is our universal sort of test for everyone. If you've had gestational diabetes before, or your doctor is particularly concerned about your risk factors, they might do it earlier. And this is sort of the diagnostic criteria that we want to see or meet to diagnose gestational diabetes. As long as you've sort of failed or you've gone over any one of these numbers, so it could be the fasting, the 1 hour, the 2 hours, as long as any of this is high, it doesn't have to be all three, just one, you would be diagnosed with gestational diabetes. So for me personally, my fasting was a little bit high. It was like 0.1 high. My 1 hour and 2 hour were fine, but I was diagnosed with gestational diabetes. And obviously at that point, when you fail just one number with a 0.1, you sort of wonder like, well, did I actually, or was it like a lab error, blood taking error? But then when I went on to monitor my blood sugars, indeed, they were a little bit raised. So then, I sort of had to change my diet anyway. But I also went through that, time of slight denial. So I understand what that feels like. You might hear things in the gestational diabetes world about how the test is inaccurate and someone tested positive and they tested negative and things like that. That's often to do with the screening. So countries like in the US, they sort of do like a risk factor based screening and a non-fasting 50 grams test first. And if you test positive for that, then they go on and do the 75 grams. In Singapore, we don't do that. We go straight to the 75 grams, which is the sort of, I guess, more gold standard testing or more accurate testing. And there was also a study done on why we do this. The Gusto study is like a really big, a lot of our maternal and newborn infant health data comes from this study. But essentially, they found that when we did the screening test first, it did not sufficiently predict gestational diabetes risk and actually failed to detect half the cases in Asian women. So in Singapore, that's why we go straight to that 75 grams test because we know it's more accurate. But this is just a little bit of background because you will hear things online that say that the test is not accurate and they're talking about the screening, which we don't do here anyway. So that test that we do here is an accurate test.
Okay.
So complications, and I don't say this to scare you. I know it's very stressful to have gestational diabetes. I 100% do not believe it's your fault, and I know that as a mom, you want to do your best for your baby. So this is not to scare you or to guilt you, but this is in some ways to just also give you the knowledge. And I guess the reason why you want to be really, I guess a little bit more hardworking around this time to manage your blood sugars because they are a risk. So to the mom, we're looking at risk of high blood pressure. So that's preeclampsia and pregnancy. Increased risk of UTIs, delivery complications for you, higher rates of cesarean deliveries as well. And for the mom, very significantly, future risk of gestational diabetes and type 2 diabetes as well. For baby,
Can I jump in here very quickly? Because on that slide, I think a lot of doctors, in my experience, and I'm a birth doula for those who don't know, and I've done over 400 births here in Singapore, and we see a lot of differences between the doctors who here in Singapore and how they manage a client with gestational diabetes. Unfortunately, the big majority will automatically jump into high risk mode and really actively manage your birth, and will absolutely have a tendency to talk you into an induction very early on, say at 38 to 39 weeks. They're scared of big babies. And so I think the induction rates are super high with clients who have gestational diabetes. And if you read up, you will see that inductions carry inherently an increased risk of assisted delivery, a cascade of intervention happening in your birth that is not very nice to manage. It'll not be a very blissful experience necessarily, higher C-section rates and all of that, including then going on with the baby, active management of their blood sugars in the early days, being tested every 3 hours, having that heel prick test done. And so you really also need to think about shopping around for a doctor who is a little bit more, I want to say is less risk averse and will still allow you to have a pregnancy that progresses naturally without too much intervention. And these doctors exist. So I think it's worth having a look around as well. And I'm happy to speak to anyone who has this diagnosis and is worried about how their pregnancy and or birth rather will be managed. Sorry to interrupt.
No, I completely agree.
Yeah.
And I feel like sometimes it can feel like, oh, am I being like anti-medicine by, saying I want like a less intervention, I guess. But my perspective always is like, I don't think I am emotionally drawn to either side of that medicine discussion. I simply look at the evidence, and the evidence base is there. And if anyone would, you could just Google it, like Singapore Gestational Diabetes Guidelines, the College of Obstetricians in Singapore. If you look at their guidelines, it actually says you can go to 40+6 comfortably. And I think I personally see it a lot as well, where people get persuaded into inductions at like 38 weeks, when realistically not many babies are born then, and you could go a lot further as well.
Very true.
And again, with all things diabetes as well, if your blood sugars have been really poorly controlled, then I understand why your doctor is going to want to be a bit more active in your management. But since diagnosis, your sugars were actually really good, then in a lot of ways, you're actually no different from anyone else who didn't have gestational diabetes. And in some ways, you're actually potentially even in a better place, because we have had very close look at your blood sugar, and we know that your blood sugar has been good. Because like I said, insulin resistance goes up in pregnancy. So there are some people that pass their OGTT and they don't get diagnosed. But then later on, like week 30 onwards, if they're eating a super high carb diet, they could be having high blood sugars without knowing as well.
Exactly. And to the first point on risk to baby, I do want to say macrosomia, that is another big topic in the birth world, where, we know how inaccurate the scans actually are, so it's really, even the scans are a guess. And have seen moms who've had a difference of a kilo between what was estimated and what the actual birth weight was. And we know that induction, so there are lots of studies, and I'm happy to point you to those, that say a big baby is not a good reason to induce, especially because it comes with, we do not see better outcomes, whether we wait or whether we induce early. So that is a good thing to take on board as well.
And just like I guess my own personal story as well is that I had to switch obstetricians at the last minute, because like my baby was born on Christmas Day, which is not a good idea in terms of like having your care team, because everyone goes on, on leave and holiday. So everyone on my team was going on leave. And I had to change obstetricians, which I was worried about. And I definitely wanted, hands off if possible, minimal intervention. But my new obstetrician that I, was assigned to was brilliant. And I was at like close to 40 weeks, a little bit worried she was going to start pushing me, but she was completely, like, look, your blood sugars have been fine. In fact, I was still testing 4 times a day. She's like, in fact, I'm happy for you to like test a few times a week, because you've been doing this for 10 weeks and your blood sugars have always been good. And I won't even discuss any management until we're closer to like 41 weeks. I'm happy to let you go through them. And my baby was born on 40+1. 40 plus too. So yeah, these obstetricians do exist. And I do think that knowledge is power. And if you're not comfortable with a decision, just talk to someone, talk to a doula that you trust, talk to people in the space.
Exactly. We have some questions, and I don't know if you want to finish the slide first with the risk to the baby. Maybe
Sure,
do
I'll
that.
cover this. Yeah.
Okay, and I'll two questions.
So risk to baby, we know that higher weight is a problem just because with higher blood sugars, baby tends to be like absorbing lots of nutrients and can be bigger. And that increases risk of a larger baby of things like shoulder dystocia and an increased risk of having a cesarean delivery. Fetal abnormalities, respiratory distress syndrome, low blood sugar after birth. So if you've had gestational diabetes, they will test your baby's blood sugar after birth. Routinely, as long as all the tests are okay, it's about 3 tests in the first 24 hours. One thing I will say there as well is that especially if you're working with doula, they can teach you, but expressing colostrum, to have colostrum to bring to hospital, can be really handy in this situation. So 100% if you've got gestational diabetes, talk to someone about having at least a few little vials of colostrum, just as a backup in case baby's sleepy and don't want to feed, or just in case you as a mom, for whatever reason, can't breastfeed then and there, it can stop or prevent this sort of low blood sugar, which means baby can go home earlier, which everyone's happier about as well. And for baby, future risk of type 2 diabetes and obesity, which for me as a dietitian, I'm really passionate about because I spent a lot of my career working in end stage type 2 diabetes. The ability to help prevent diabetes from right from the start with a baby, I think is really powerful as well.
I want to add here quickly about the colostrum harvesting. I also recommend that to all gestational diabetes clients. And the reason is that they're very, very quick to push formula and that they give formula at an amount where the mother's body is not able to catch up with the volume that the baby has been receiving. So I think having prepped your body that this baby is coming and you already know how to express the colostrum, you can minimize the giving of formula by giving your own what your own body produces. And I think that's really, really important. Okay, I have a question here. What is the risk of actually having gestational diabetes later in the pregnancy? Let's say you've passed the GD test, but on the borderline, like getting a 0.1 point below the GD rating on all the 3 tests.
So we don't actually have specific statistics because it's hard to, I guess, like track. Because as the pregnancy goes on, that insulin resistance goes up. So it's very hard to get a specific time point. But we do know the risk is there. So if anyone's concerned, I think getting a blood sugar monitor and doing intermittent monitoring, and personally myself, as someone who's had gestational diabetes in the past, and hopefully I'll have another pregnancy in the future for number 2, that would be my plan. Even if I passed my second GD test, I would be inclined to monitor my blood sugars on and off, just to make sure that as the pregnancy progresses, my blood sugars are still within range. Because I don't know for sure whether my blood sugars will stay within range. And especially if you sort of just passed it and you're concerned, I would say your intuition is great. And generally, if you're concerned about something, it's valid. So I would say just do a bit of testing. Doesn't have to be every day. You could do it like twice a week. Just do it, 2 hours after your meal. Make sure your blood sugar is within that benchmark number. Because again, really hard to say. There have been research, that looks at doing a repeat OGTT later on in pregnancy. But again, we do know that it's a very involved process. Like nobody looks forward to their OGTT and we don't do it that often. So I would say that's my best bet. Otherwise, again, everyone's going to benefit from watching your blood sugar levels and making sure your meals are well balanced. So I guess that's the flip side of that as well.
Yeah, and we will talk in a little while about how you can be testing your blood sugar at home by yourself. We've got another mom who's raised her hand. Would you like to speak now?
Yes, thank you. Hi, Trina. Hi, Annabella. Just a question because I heard, that you mentioned carbohydrates a few times. So maybe it will come a little bit later in the presentation. But you mentioned that you cut down on carbs when you got diagnosed with diabetes. And then, but what does that mean? Does that mean starch? Does that mean fiber? Does that mean sugar? Just to elaborate a little bit more about that. If it's not now, a bit later in the presentation, it would be fine as well.
Amazing. That's actually coming up very soon. So it will be covered. Leah, if you still have questions, please raise your hand again.
Sure, thank you.
Yeah, so we'll talk about carbohydrates in a little while, and hopefully I'll answer all those questions then as well. So just a bit about testing blood sugars. Once you've been diagnosed, most of the time you'll get asked to test your blood sugars 4 times a day, depending on where you're at. Some people in the early weeks or some doctors in the early weeks even want you to do more. So they might also want you to do like a fasting, pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner. Some doctors require that. Some just say 4 times a day. Generally, 4 times a day is a good number to aim for, especially in the early couple of weeks when we're monitoring your blood sugars a little bit closer. But these are the numbers that we're looking at. Once again, if you compare this to type 2 diabetes, you will see that these numbers are a lot lower. But that's simply because your blood is so much more diluted because of the increased blood volume during pregnancy, that those numbers do come down a little bit. And this is what, ideally they should be sitting at. So there are a few options with testing your blood sugar. The first one is a traditional finger prick test. So you can get these test kits. It comes with a little monitor, lancet, which is basically like a needle. It looks a bit like a staple. Like it has like a, how do I describe it? Like a little mechanism where it sort of a needle sticks out and pokes you, and a little bit of blood comes out onto your finger. It's got a little strip where you put your blood in, and then you insert that into the monitor, and it will give you your blood sugar. So this is generally deemed as most accurate just because it's a more traditional way of testing. So we have longer research. It is more accurate simply because it's got more research, I guess, and it's using actual blood. It's a bit more affordable. Well, actually a lot more affordable. My massive tip here is that if you do have gestational diabetes or you are buying the tests, do not buy your strips online. Do not buy your strips from a pharmacy. Buy them from a hospital pharmacy. So either like a Diagnosing pharmacy or the NUH pharmacy, any government hospital pharmacy, or I think polyclinic as well. It is much, much cheaper. And even if you just Google it later, like 100, AccuCheck test strips, you will see that the Diagnosing pharmacy price is like a third or at least half of even your Shopee discounted prices. And that's because diabetes is such a big thing in Singapore, the government directly subsidizes it through the hospitals. So make sure you're buying your test kits from the hospitals instead. The downside to this, of course, is that you have to prick yourself, which is not fun. It does not provide you a continuous picture of your blood sugar. So if you're not testing, you don't know. And you have to carry around this little test kit. In saying that, it does come in a little pouch, which is quite neat. It's not giant, so it's also not, it's not fun. We prefer not to do it, but it's not the end of the world as well. Your other option is a continuous glucose monitor. So this is like a little sensor that sits in your arm. You can apply these yourself. You do not need to go to a doctor or GP to get it done. You buy it from like any pharmacy, hospital pharmacy, Watson's Guardian. It comes with an applicator. So you'll see the sensor. It looks like a big hole punch basically. And you just push it to your arm. I would say it's not painful to insert. It is, a little bit of a shock, maybe like an injection, because it does have a little needle applicator, but not overly painful. Once it's in, you're not supposed to feel it, and it stays in for 2 weeks. It is a little bit more expensive. So as opposed to, I calculated about $15 per fortnight if you're using 4 strips a day for 2 weeks. With this one's $103 per fortnight. So quite a bit more expensive. In saying that, for a lot of people, if it means that you don't have to prick yourself or worry about one extra thing in pregnancy, that can be handy. The other advice I like to give is perhaps we do 1 round of the continuous glucose monitor in the first 2 weeks. And then after that, if things are well controlled, we can move towards the finger pricking. So it doesn't have to be one or the other. You can use a bit of both. If you read the instructions on the sensor, it will say that it's not validated or researched in gestational diabetes. And that's not because it doesn't work. It's just because they haven't done the research, and the companies will say that it's not validated. But we've done the comparing the two. It is accurate, and it is fine to use as well. And most of your obstetricians or gynecologists will support the use of a continuous monitor as well. The power of this is that it gives you your blood sugar in real time. So you can scan at any point. A lot of the sensors only store about 8 hours of data. So you sort of have to scan at least every 8 hours to download sort of what your charts look like. And for instance, if it's the weekend, you're having a big sleep in, you slept for 10 hours, you will miss a little bit of a window there, but that's also fine. But it does give us this continuous picture. The power of this is, we know that with gestational diabetes, exercise can be a really big one.
Just mention that, yes, because I've seen that in a client actually as well, how different it was actually. But go ahead, sorry.
So I think sometimes, especially when you're pregnant, there are times you just want to eat like a pizza, which we know is going to be a higher carb meal, and that's fine. and you just really want it, but you also don't want your sugars to spike. It does give you this allowance to see what your blood sugars are doing and time your exercise accordingly, or, see what that looks like for you. So an example would be, when I was pregnant and had gestational diabetes, my husband and I might go have a pizza or some food. And then after that, we'll just go for a walk at Botanic Gardens, and I'll keep an eye on my sugar levels to make sure that it was coming down. Or if, after a meal, I'll look at my sugars and go like, oh, it's looking a little bit high. I would just go for a little walk, and that can bring it down a little bit more.
Interesting.
The other side, yeah.
I just want to add, my client found a huge difference between the type of exercise she was doing. So she was noticing same meal, same thing, etc. Walking versus swimming versus, I don't know, playing tennis, or made a difference as well. And then she found the exercise that was most efficient for her to bring down her blood sugar. And that is really cool to see as well.
Yeah, for sure. Exercise is really powerful, especially in gestational diabetes. And I reckon it actually helped keep me really fit towards the end of pregnancy as well. The other power that I do see, which is the opposite side, because I also get clients who have really bad like nausea up till the end of pregnancy, and they're juggling both gestational diabetes and a lot of nausea, and they're struggling to eat enough. With the traditional finger pricking, often we say don't eat 2 hours after a meal. Like 2 hours after your meal, don't eat anything, test 2 hours after, see what your blood sugar is doing. If everything's okay, maybe have a snack. But with a lot of my clients, it can actually get tricky to fit in all the meals. So with the monitor, my advice then is to even if it's like an hour and a half later and your test and you scan and it looks okay, you're okay to have a snack there. Because especially for clients who are struggling to fit in enough food, having to wait a whole 2 hours after each time they eat it basically reduces the number of times you can eat in a day. So that can be powerful there as well. You can share your results with your care provider. I will add that this process can be finicky. I've had it fail on me here and there, but if all things go well, you can actually add your care provider in, and your care provider, if you allow it, can see your blood trends without you having to upload results or tables. The two main brands available are the Abbott one and the Dexcom. They're both fairly similar. Abbott has a slightly more user-friendly app. It is a smaller sensor. The Dexcom is bigger. Anecdotally, according to my colleagues and things like that, people seem to think the Dexcom is more uncomfortable to apply, a little bit more painful on insertion. I didn't find that. I find them both the same, but that's, again, very subjective to the person. If you look at the price of the Dexcom, it's going to look slightly cheaper, but that's because each sensor for the Dexcom lasts 10 days, whereas for the Abbott one, it lasts 14 days. So price-wise, to be honest, they're quite similar. Product-wise, also very similar. It's just two options that you have available to you. So yeah, that's what continuous monitors look like. Managing gestational diabetes. So again, combination of diet, exercise, and perhaps insulin therapy. Some obstetricians in Singapore do oral pills like metformin as well, although a lot of people go to insulin because metformin's efficacy is not, I guess, as well researched as insulin. I will say though that with gestational diabetes, your runway to manage it is really short, because if you get diagnosed in your third trimester, realistically, we don't have that many weeks to get everything under control. So there is a level of urgency, as opposed to type 2 diabetes, where the doctor might say, go back and try this and try that. We're looking at you a lot closer. Most of the papers say that you've got about a 2-week lead time to control it with lifestyle before we introduce medication. In saying that, I see the management by obstetricians to vary greatly. I see some obstetricians that are really proactive and give you diet advice and tell you what you should do. I see some that give everyone a really fixed meal plan, which I don't thoroughly agree with as well, because everyone's diet is different. Everyone needs a different. So I don't think a strict meal plan is the way to go. But I've also seen the complete opposite, where some doctors will say, you've got it. I just want you to go back and do everything that you're doing now and test your blood sugars, come back in a month, and I'll start insulin if I need, which I also don't agree with, because I think there's a lot of lifestyle change we can make as well. So looking at how we manage it, we want to choose carbohydrates with low glycemic index, and I'll cover a bit more about GI or glycemic index in a while. Increasing our fiber intake, having regular meals, learning how to balance your meals, including exercise if tolerated, and limiting sugary foods and drinks. I'll cover exercise quickly now because I don't really have a slide on that. But essentially, there was one paper that said that even 10 minutes walking after each meal had a really positive impact on blood sugars. So it's not uncommon that in pregnancy, a lot of moms don't feel so comfortable, especially in the third trimester, might not be feeling like they want to do like an intense 1 hour workout. And you don't actually need that. Even like a 10-20 minute walk after each meal can make a massive difference to your post-meal blood sugars, and actually helps a lot with activity as well. That's walking and maybe more cardiovascular exercise. But at the same time, we also know that weight training can decrease your rates of insulin resistance. So doing some weight training can make your body more sensitive to the insulin you're making. So combining a bit of both in a way that's comfortable for you can be really powerful in pregnancy, but especially in gestational diabetes as well. So we've talked a lot about a lot of other things. Now we're going to talk a little bit more about diet. So that first little bullet point, that's from that research that says, ideally, we have about a 2-week window to manage diet first. Because upon diagnosis, a lot of people ask me, oh no, like, do I have to start insulin right now? And the evidence-based answer is, we'll give you 2 weeks to adjust diet. Maybe in the first couple of days, you'll see some higher blood sugars as you're learning what works for you. Don't freak out yet. You're within that 2-week window of trial and error. Ideally, in that 2 weeks, we can really be quick at bringing your blood sugar down. So I think with a lot of gestational diabetes, I've had some moms reach out to me and then they say like, oh, I'll try on my own for like a month and then I'll reach out to you if I'm struggling. But realistically, a month's a very long time in pregnancy. So my advice is to try for a couple of days. And if your sugars really are high and you're struggling, reach out for help early, because if it can mean that you don't have to get insulin, that's ideal. Because it's always better to, just be on diet control. And it's not necessarily a plus point or a good thing, but also a lot of doctors tend to see gestational diabetes managed just by diet versus insulin as two completely different beasts. And there is research behind, if you need insulin, yours is probably a more complicated case of gestational diabetes. So there is benefits to staying off insulin if possible. In saying that, there are some moms who simply need it, and that's completely okay as well. But I guess my point in this is to say that we should really try lifestyle first for at least 2 weeks, and you should give it a good shot with like the appropriate amount of support. And that bottom bullet point, again, is from the Singapore College of Obstetricians, and it says that all pregnant women should be referred to a dietitian, which I am struggling with this point. So if anyone has a obstetrician that wants to refer to me, please let me know. Happy to reach out to them. But yes, I do passionately feel that everyone needs a dietitian if they've got gestational diabetes.
Yeah.
So this is just a really generic diet. I don't love these diet images because everyone's diet is different. Everyone needs something that's slightly different, but this is a good rough, image of what we need in gestational diabetes. But realistically, everyone, pregnant, not pregnant, the ratios might differ slightly, but ideally, most of our diet should be non-starchy vegetables. Most people don't get enough, non-starchy vegetables. We want a good amount of lean protein, especially in pregnancy. Your body is building a brand new human, and your body is also building a home for this baby. So your body's expanding and growing. We need lots of protein, make sure we get enough. Carbohydrates, we still need it even in pregnancy, but of course we want to get carbohydrates from lower GI sources. So less from your sugary drinks, but more from low GI sources like potatoes, sweet potato, pasta. And we'll talk about glycemic index in the following slide. So just a little recap. Yep.
Can I add something quickly? So the plate method is what I share with all of my clients as well. And I think it's a very easy one. And it's one that I follow as well. With every meal, I look at my plate and I say, where can I make simple, quick adjustments? What a lot of people don't know, and what is not immediately visible on this slide, I feel, is that fruit sits in that category of carbohydrates as well, because half of the plate should be fruit and vegetables, but that's not the case. So it's not starchy vegetables, and the fruits are in carbohydrates. And if you look at it, most people will struggle at breakfast, for example. What do we have at breakfast? Yogurt, granola, fruit, and we think that's super healthy, but it is 100% carbohydrate, So yes. This is really important to note as well. And this is where people struggle, and this is why you benefit from seeing Annabelle, because she will give you actually ideas of what a meal could look like for you. Sorry.
No, you're completely right. Breakfast is one that people tend to struggle with. Most of our breakfasts tend to be really low protein. And even like having one egg is not actually a very high protein meal, because eggs are high protein, but one is not generally enough. In saying that, most people struggle the most with blood sugars in the morning. So generally, like if there is one meal that people tend to have higher blood sugars with, it will be in the morning, just because your pregnancy hormones are the highest at that point as well, which is why traditionally we call it morning sickness, although we know that most people have all day sickness, but that's that tricky point. So some people even need to split up their breakfast into 2 portions to avoid having high blood sugars. So definitely traditional breakfast meals that are super high in carbohydrate, not really ideal.
Yeah.
So just giving you a brief overview of what macronutrients are. So macronutrients are nutrients that we need in larger amounts. Protein, we definitely need in pregnancy. They're good for muscle growth, maintenance. They keep you full, and they help with blood sugars. Carbohydrates, still really important, a good source of energy, a good source of fiber, but they do affect your blood sugar. So we have to be very mindful of the portions you're having and the types you're having as well. Fat, it's actually really, really important. Definitely pregnancy is not the time to go low fat. I dare say most people do not need a low fat diet. And some fat is needed for cell function, hormone synthesis, and definitely omega-3. So things like your oily fish, super good and great for brain development as well. What you will see is that there's some foods that sit in the middle. So things like dairy has a bit of everything. Hummus has a bit of fat, a bit of carbohydrate. Beans have a little bit of protein, a bit of carbohydrate. So we have to be aware of what our food contains, because for instance, if you're having like beans and rice, that could be a reasonably balanced meal. But if you've got gestational diabetes, you're doubling up on the carbohydrate, and that could be quite a high carbohydrate meal.
I have a question in the chat. Let me just read it. Sorry. Sorry if my question's below. You know what? I would love for you to finish the presentation, and then I'll ask because there are a lot of questions.
Sure. Okay. Let's do that. So managing carbohydrates, we don't want to go a 0 carbohydrate. Also, that's really hard to do if you're pregnant and hungry. So we still want to include some carbohydrates and really nutritious ones as well. However, the type, how often you're having it, and the amount will impact the blood sugar. We do count it as exchanges. That's like how money, we use dollars. With carbohydrates, we use the term exchanges, generally about 15 grams of carbohydrate. And that recommendation as to how much you can have is really individualized. So that's one of the big things that we do in gestational diabetes consultations, is to work out what that number looks like for you. So if we work out that you can have 45 grams of carbohydrate for all your main meals, that gives you that flexibility of going, okay, I can have 45 grams. These are all examples of 45 grams with the different portion sizes. I now have the flexibility of picking different ones. Because I also get some moms who they do a bit of trial and error, and then they have to be super strict. Like, I can only have one slice of bread, like half a cup of oats and this, and then they hate food by the end of it because they haven't been allowed to have a varied diet.
Yeah.
And who wants to eat like that? So, working for Dietitian can give you that number really quickly, hopefully. I have some clients who are brilliant, and they come to me already with like a spreadsheet with exact carbohydrate portion sizes and their blood sugar levels. And very quickly, just within that one session, we can work out what that number sort of looks like. And they go away knowing all the different carbohydrate foods and the portions they can have, and also mixing and matching. So they've got more option for variety. So really the first step in managing your gestational diabetes blood sugars is carbohydrates, and working together with a dietitian is the quickest way of doing that if you're struggling a little bit on your own. At this point, we'll talk a little bit about glycemic index. So again, like a lot of guidelines will say that, with GD, we want to recommend foods that are low GI. I personally don't think that covers the whole picture, because glycemic index is how this particular food raises your blood sugar. But we know that we don't eat just carbohydrate foods. You don't just eat a bowl of rice. You don't just eat a slice of toast. You eat it with other things. And that affects what your blood sugar looks like. And that's called the glycemic load. Also, glycemic index is individual for everyone. So what is considered low GI for me might not actually be that low GI for you. So I don't love the glycemic index. Glycemic load is a better idea because it tells us this whole meal. And generally, by balancing your meals and snacks, so combining a carbohydrate, so something like a banana, with some protein and fat, like an egg or almond, you will see a lower spike in that blood sugar, because with combined foods, it slows down that release of blood sugars. We're not getting big peaks. And this applies for everyone. Even if you don't have gestational diabetes, even if you're not pregnant, by doing this, you don't get that big, sugar spike, but you also stay fuller for longer and you're more satisfied. I've got a short list of GD mantras here, and I know this sounds like a little bit cheesy sometimes, but in gestational diabetes is an emotional roller coaster. There will be times where you feel really like guilty or stressed, and having some of these mantras can turn a not so nice situation into like a little bit more encouraging, I guess. So knowing it's not your fault, knowing that you can manage it. Most people can manage with enough support just with lifestyle change, but if you need medication, also not the end of the world. That nourishing, like being really like paying lots of attention on your food means that you're nourishing yourself and baby really well. You're also going to be learning so much about food and nutrition. Some people tell me that this is sort of like a stress test. You know that you're at higher risk and you wouldn't have known if you didn't get this positive test. And now you can make the change, which means that down the line, you hopefully won't develop type 2 diabetes. Your eating habit is going to affect your whole family. So your whole family is going to be healthier for it. And if you get occasional spikes, don't be too stressed because I know you're going to be doing your best. And you're also not defined by your blood sugar levels. Your sugar levels don't have to be perfect. They just have to be good enough and within range.
Yeah. And I would add to that. Oh, sorry, go ahead.
Sorry. Yeah, no, you go ahead.
No, I was just going to say it is so helpful as well. As you say, it's a lifelong learning. It is a lesson that pervades throughout our lives and the lives of our children as well. Because especially a mom who's had gestational diabetes needs to be giving their babies or their kids a good start in life as well, because they have that increased risk themselves. So when we introduce solids, being really mindful of what we introduce and cutting out the sugars and giving them a really balanced meal for every solids meal as well is super important. And starting these early habits, it doesn't feel like a chore. If we've never eaten right, if we've had a crappy diet all our lives through no fault of our own, because we are also the result of our upbringing, right? But then it's really, really hard to certainly be perfect, have the perfect, or as you say, good enough with making these changes to our diet. But if our kids have been growing up with that plate method and they know all or have always enjoyed these meals, then I think they're much better off.
And you're totally right. And as a dietitian who works in, prenatal health, but I also work with pediatrics patients as well. I am such a firm believer of that family meal and what the parents' diet look like. And I usually find parents are like really passionate and proactive in that first year. But then after that, by like 4 or 5 years old, a lot of parents are like burnt out from being so involved. So my advice really is to focus on your own diet. And most kids end up eating what the parents eat. So focus on your own diet. How can you modify that to the kid? And the whole family eats well. And a healthy family, healthy parents have healthy kids. So we really want to focus on that family ecosystem and not a different diet for everyone in the family. So after gestational diabetes, your risk of developing type 2 diabetes is 8 to 10 times higher. This range varies greatly based on the study you look at, but we know it is higher. Breastfeeding postpartum can help reduce this risk. So we should really hope to be supported enough breastfeeding if that is your choice. We should be doing a repeat tolerance test, and your obstetrician should be organizing this for you at 6 to 12 weeks postpartum. If for whatever reason your obstetrician is not doing this for you, you can do it at the polyclinics as well. Thereafter, we want to be screening for diabetes annually. The guidelines say if you're not at high risk, you can do every 2 to 3 years, but realistically, getting a fasting blood sugar is not expensive, and you should be doing health screening every year anyway. So I will say just do it as part of your annual health screening, and we need to ensure a lifelong, healthy diet and activity level as well. If you're concerned about your future risk of gestational diabetes, or if you've had GD with your first pregnancy and you're looking into going into a second pregnancy, of course, make sure you're eating healthily, exercising regularly. Strength training is really important. Having enough muscle is really important. There are some supplements we can look at, but that should be tailored individually as well. So if you want, then a dietitian can help you out there as well. So just a quick explanation of what working with a prenatal dietitian can involve. Prenatal dietetics is a really new field. I think the physios have done a really good job. Nowadays, most people go and see a physio when they're pregnant, but a dietitian also is a big part of that. And I'm hoping that in the next 10 years, we become, as strong a part of everyone's care team as a physio, even if it's just one-off appointment, that can help you greatly with your pregnancy nutrition. So with a dietitian, we can review your blood work. We can recommend prenatal supplements. So prenatal supplements cost a lot of money. And a lot of people are taking ones that give them too much of things they don't need or not enough of things they need as well. So 100% should be tailored to you and your diet. And if it's something that we can optimize through your diet, like you don't need a supplement for, that's also better. So working with a prenatal dietitian can help you there as well. Food safety advice. So I see a lot of moms who are like avoiding like a lot of food that they don't have to avoid. And there's also a lot of research that says that avoiding too many foods can reduce how nutritious your diet is as well.
Absolutely. I totally agree with that.
So I can provide you advice around that. Managing pregnancy symptoms like nausea, constipation, managing low iron, gestational diabetes, and we can reduce risk of complications based on your history as well. Specifically with gestational diabetes, we do the same thing like blood work, prenatal supplements, but we also work out your carbohydrate threshold, so you've got more flexibility with your meals. The other really big part of it is we don't want your diet to be too restrictive, which can also happen because we want to make sure that your diet is nutritionally complete and you're getting all the right nutrition for your baby and for you while keeping your blood sugars good. We also look at recipes and strategies for eating out. And in my package, I also have like a postpartum one because I also like to make sure that mom is all good to go in that postpartum, season to make sure that we're preventing the risk of type 2 diabetes later on as well. And that's us. We have questions, don't we?
I know we have only 4 minutes, but actually, if you are happy, I'd be happy to go
I'm
over.
happy.
Do you want to sharing your screen for a minute and I'll go into the messages?
Sure.
Okay. One of our mummies is asking, sorry if my questions below have been discussed as I came in late. Does making diet adjustments from the first trimester reduce the risk of getting gestational diabetes? Ooh, I'm at the end of my hour. I can see that. Okay.
So yes, try to do it point by point. I think it's probably easier. The quick answer is yes, it does. They have done studies that say that even from the first trimester, looking at blood sugars can predict your risk of developing gestational diabetes later on. And as we know, it's a continuous relationship. So the higher your blood sugar, the higher the risk. I will also say that as someone who is a dietitian, of course, I'm passionate about nutrition, but your body is literally building a brand new human. And just like how we're building a house, you need different parts. With building a baby, you need different parts as well. We want to make sure you're getting enough nutrition. So I think everyone should be making diet adjustments for a healthy pregnancy, but definitely can reduce the risk of gestational diabetes as well.
Okay. And then is the issue with gestational diabetes simply about any spike above the threshold, or is it persistent high sugar levels?
It's a little bit of both. So we are looking at the time you spend out of range. If you're having spikes fairly often, though, that increases the total time that you have in that higher range. And again, because we know it's a continuous relationship, ideally we keep all the blood sugar in that lower end for best outcomes. I don't want parents to get too stressed about occasional spikes, but if spikes are happening frequently, we need to start looking at why that's happening, I guess.
Okay. I had GD in 2 out of my 3 pregnancies. In the 2 pregnancies where I had GD, the babies had slow growth from 30 weeks onwards due to poor blood flow from the placenta. Is there a known study that GD causes the placenta to malfunction? And if yes, is there anything that could be done to prevent that?
There is no study specifically looking at GD and placenta, issues as far as I'm aware, in saying that we do know it's a risk factor for, I guess, more complicated deliveries, and also, I guess, with placenta issues, it tends to lead to preterm like deliveries as well. And we know there's a relationship there as well. In general, to be honest, a lot of blood flow issues might not be something you can directly affect, but a good diet is protective of a lot of other things in general. So like I always say, we can't control everything, but we can control a few things, and working within those things we can control can definitely be helpful.
I've had GD in my recent pregnancy. I've delivered a healthy baby, but very keen to know if there are any tips or suggestions to reduce the risks of pre-diabetes, diabetes for both mommy and baby later in life.
Yep. So like I said in one of the earlier slides, we really want to look at a healthy diet. So making sure you're eating a healthy, balanced diet that's going to keep your blood sugars nice and stable, avoiding too much added sugars. We had one question earlier about like carbohydrate sources. Ideally, we want more like whole grains, so from some fruit, from some vegetables. We want to avoid excessive amounts of, like refined carbohydrates, and of course, exercise. Having enough muscle mass, especially as women as we age, activity, lifestyle, stress, all these are diabetes risk factors. Maintaining a healthy weight, although I say that lightly because we know that weight's not a direct indicator of health, so we definitely look at diet instead. So yeah, those are the few things that we can do to make sure that we have a lower risk of diabetes for everyone.
And what about the baby?
Yeah.
Later?
So Yeah, so babies definitely have like a higher risk of diabetes. And I think to me, that's one of my like big passions around gestational diabetes. There's also some increasing research. You know how if you've got a female baby, baby is born with all their eggs.
Yeah.
Like we as women, we're born with all our eggs as well. So there is some research looking into, are we then affecting metabolic health 2 generations down? Which as a dietitian is super powerful because I'm helping a mom like right now today, but this could affect this family 2 generations down, which is huge. So again, for babies' health, we want to make sure that babies eating a healthy, varied diet. Um, I am really passionate that the way we feed children is going to be how they eat much later down in life. I have clients who like are in their 50s and they tell me things like, oh, I don't eat this because growing up, I never did. And clearly 50 years down, the way your parents fed you still matters. So as a parent, you play a massive role in how you influence your kids. And a lot of parents also get really stressed. All kids go through a fussy eating phase. That's completely normal. Parents get really stressed about it. But I always remind parents, like, think about your own diet. It probably looks quite similar to what your parents ate. And there are often things like, for example, you might grow up with seeing your mom eat sardines and thinking that's gross as a kid. Next minute, you're 35 years old and you're eating sardines. And you're like, wait a minute, like, I am now my mother. So as parents, you've got a big influence of your kid's diet. So definitely eating a healthy, well-balanced diet helps you, but also helps your baby as well.
One of your slides earlier was saying that we should be recommending that gestational diabetes moms are encouraged even more to breastfeed. So what is I'm assuming that it's the connect between breast milk and formula not being really equal. Are we introducing more sugar into a baby's diet when we formula feed?
A lot of the research around, I mean, we do know that the research around breastfeeding and better metabolic health is separate from gestational diabetes, so that makes sense. In general, we know that babies who are breastfed do have better health outcomes. In saying that, I also say that lightly because if breastfeeding isn't working for a mom and it's causing her great stress, then it's also not working for that family. But around gestational diabetes, a lot of that research actually looks at moms. So breastfeeding has a lot of health benefits for moms as well, including like lower risk of breast cancer and things like that later on. But definitely with gestational diabetes, there is a relationship between breastfeeding for longer and a reduced rate of type 2 diabetes later on as well.
Amazing. I never knew that. That's really important to know. Okay, my fasting blood sugar went back to normal after delivery. Do you recommend making diet changes and monitoring blood sugar level after delivery, even if blood sugar is normal? As I understand, there's a high likelihood that we get diabetes later in life. I think that was on one of your slides, wasn't it? But if you want to...
Yeah. So yeah, definitely. It usually does go back to normal just because the hormones have normalized as well. But even if it does go back to normal after that, it just means that you don't have type 2 diabetes. It still means that your risk is higher. So making sure that you continue to eat a healthy diet to prevent that future risk of diabetes is still really important as well. Because I guess a high blood sugar is a sign that diabetes has already happened, but we don't actually know what's happening in terms of like, is it developing? So we want to make sure that we're eating a good diet to stop it from happening in the first place.
Yeah. Okay. And then someone is asking about sugar replacements like xylitol, monk fruit sweetener, etc. A good thing or the safe option for pregnant women to control their glycemic index a little bit and choose sweeteners or sugars that are a little bit more healthy and balanced.
Yeah. So a lot of research around this area as well. Ideally, I mean, if you are choosing to use a sugar replacement, we want like the more natural ones. So unlike aspartame, we want things like monk fruit or stevia that are a little bit better. But in saying that as well, we do know that for some people that can actually affect the blood sugar. It can also affect sugar cravings and things like that. So my advice around this realm is, if possible, just avoid all sweeteners, and because generally they come in processed foods as well, which we want to be aiming for a more whole food diet. So my, best advice is to avoid where possible, regardless of the type of sweetener. But if you're having something with artificial sweeteners, then choose something like a stevia or a monk fruit that is better than the more artificial ones, I guess.
Amazing. We're at the end of our questions. I wanted to mention the go-to book for me is Lily Nichols and her book on real food for gestational diabetes. Have you got any other resources that you'd like to share with mummies?
To be honest, she's the best one. There are a few on Instagram as well. There's like the Gestational Diabetes Dietitian. But Lily Nichols is great. She's got recipes. That book is fantastic. It's a good consolidation of all the research. She's got two newer ones as well for like fertility and pregnancy. So it's, if anyone's interested in that area, it's an excellent book, and she's an excellent resource. She also does break down like the research around different things. So if you are like at a crossroads with your pregnancy and a diet choice, if you just Google her, she probably has an article on it. And her articles are great. So yeah, highly recommend her as well.
And there's one of our mummies, and I forgot to print it out actually. One of our mummies suffered from gestational diabetes in pregnancy, and she actually published a book on recipes and how to, still have a fun and engaging diet, basically.
Yeah.
Diabetes, and I will share the details for that book in a minute. Her name is Amanda Kinder, and it's called Tasty Food Despite Gestational Diabetes. I'd love to share that with you, and I think she might have reached out to you as well, because I think it would.
Yeah.
I'd like to hear what you think of that book, but I think it's such a good resource. I've looked at it on Amazon only. I've ordered it immediately, and I'm really what it is, but the pictures look so appetizing and fun. So, that's something really good to have. But if you have other resources that you want to share with our mummies in a PDF or whatever, I'd be happy to spread the word.
Sure.
So let me know if I can share anything after. And
Sure,
then share your hand phone number, or how would you like people to contact you?
Yeah. I can send you like an e-card or my details, and that's fine. I'm also on Instagram, so if anyone wants, I do a lot of posts on like healthy eating for moms, but also kids. I think it's quite seasonal in this point of life. So if anyone wants to follow me on Instagram, that's also a good place to keep in contact as well.
So we'll share all the details in a minute, and we'll post the recording, obviously, as always, and you're more than welcome to share that with your audience as well.
Sure.
So much, Annabelle. This was such an informative session. We had so many mummies coming in and out, but I think they all found it really informative. And I hope everybody has a lovely day. This is actually the last Zoom coffee morning that we have before the new year. I'm going skiing for a month. So we will have one more that is in person, if anybody is interested. Music fun with Lucy Sparkles next week, and then we wrap up for Christmas. So wishing everyone a really lovely holiday season, and we'll see you in the new year as well. Thank you, Annabelle, once again.
Thank you so much. I had the best time. Thank you.
Okay, bye-bye.